Hey, thanks for hanging out with us here on The Big Picture. We are continuing our conversation around maternal mental health. It's something we dove into earlier this week, but it's still something that's, making news headlines. There are a couple prominent cases, but we wanted to really kind of dig into some of the facts that are going around maternal mental health. We know it's something that a lot of mothers struggle with.
Definitely. And there's been a lot of research done. And I want to bring in now our doctor who's with us, Dr. Tamar Gur. You are a reproductive psychiatrist. Jesus, it's been a day. With Ohio State University. Talk to us, I just want to preface this all. Talk to us about your work and how your work ties into mental health with mothers, expecting mothers.
Thank you so much for having me and for covering this really important topic. I think that the more we talk about it, the less there's stigma, the more people that can be helped. And so I think that's really critical that we partner together and talk about this. So my work is focused on pregnancy and the postpartum, which I refer to as perinatal, which just means throughout that whole time period. We know that's a really critical window for women and their long-term mental health. And so, if we think about transitions are hard. So when you go off to college, you might get anxious. When you get a new job, even though these are good things, it might be really hard. And, transitions are hard and people are complicated. And pregnancy is such a huge transition for the whole family, for mom, for dad. So it shouldn't be too surprising that people have increased risk of having depression and anxiety during that time.
And according to the Policy Center for Maternal Mental Health, over the last decade, they reported mental health of U.S. mothers has worsened. Between 2016 to 2023, there was nearly a 65% increase of fair to poor mental health. Is that number increasing, or are we just talking about it more?
I think it's both. And so you bring up a really good point. We need to really detect something in order to be able to report on it, right? And so a lot of hospitals, including Ohio State, now have every single woman who delivers there screened for postpartum depression or perinatal depression. A lot of pediatrician's office, my own pediatrician's office screens every new mom for it. So it's really increasing awareness that we need to be asking the questions in order for someone to say yes, that they have that. But also it is rising. So we know that things that contribute to perinatal depression and anxiety are things like, the pandemic. The pandemic, if you remember back, it wasn't that many years ago, but we were at home alone. There was a lot of very stressful. People were getting, people lost jobs. It was really difficult. And so things like that can absolutely contribute to increased rates of that. And so I'm not surprised. I'm well acquainted with that fact, but it really makes a lot of sense to me. So I think it's both.
And talk to us about the screening process. What does that look like today?
Today, so if you were over on labor and delivery today at Ohio State, a very nice social worker would come in and she would give you a piece of paper that would ask you things like, how many times over the last few weeks have you felt really overwhelmed? How many times over the last few weeks have you had trouble eating because you weren't hungry? How many times over the last few weeks have you had difficulty sleeping even if you're tired? It's really very organic. It's not a scary process, and you should really answer those questions honestly. And these questions have been validated over hundreds of studies to really be able to pick up postpartum depression.
And it is a serious thing, and it's something to be taken seriously. The CDC, reports it's not a small number of mothers who unfortunately take their lives or overdose. It's some 20% of maternal deaths following birth are attributed to suicide.
Isn't it wild that the most common complication from childbirth is suicide?
Yeah.
I mean, let's sit with that for a moment, right? That's really, really tragic. And so I think that that's why it's so important that we pick up on this, that we reduce the stigma, and that we get women the help that they deserve.
Right. And so talk to us more about the risk factors then. Obviously, suicide can be one from postpartum depression, but also then the difference between postpartum depression and then psychosis.
Yes. So also there's a third thing that we should talk about, which is called the baby blues. So the baby blues are something really common that happen up to 80% of women in the first 10 days after delivery. They might cry, oh, this is the cutest onesie, start crying. Like, oh, I burnt, dinner, start crying. Like they might just be a little bit more tearful, have a little bit harder time concentrating, have a little bit harder time regulating, just not be a little more irritable. That goes away. And up to 80%, that's almost every woman will feel some level of just, if you think about the hormonal fluctuations, if you think about just all the changes, the sleep deprivation, that can be understood. But for about a quarter of women, it comes into roost, settles in and becomes postpartum depression, which can include suicidality or thoughts of not wanting to live anymore or hopelessness, but really can also just be difficulty enjoying things, not looking forward to anything, feeling sort of hopeless. So that's postpartum depression. Postpartum psychosis is a completely different disease from our understanding. And there's been a lot of conflation recently that they're the same, but they're not. They're completely different. The neurobiology is different. The course of the illness is different. And it's one of those do not pass go, do not collect $200 emergencies. If that is a suspicion I have for a patient or if someone in the community has immediately go to the emergency room. There needs to be a hospitalization, and that it's a completely different disease than postpartum depression. But we start getting worried. Patients who have postpartum depression, they've been hearing so much about it, that can even reduce their urge to talk to someone because they're scared they'll be labeled as crazy and have their children taken away.
Right. So what would you say are the biggest differences between, really being sad and depressed, maybe like having difficulties getting up, and then
Postpartum psychosis.
Psychosis.
Yes. So psychosis is a completely different disease. So it's disorganized thoughts. So your thoughts are going in 1,000 different directions. You're seeing connections that aren't there. You're really having trouble getting through your day, not just because you're tired and a little bit having trouble concentrating, but really your thoughts are completely disorganized and headed off in lots of different directions. You have delusions, which are false fixed beliefs. So a concern that you're being stalked, or concern that you've been possessed. Just really delusional delusions, like frank delusions that are not reality based whatsoever. So those are the two main. You're hearing things in addition to you're hearing voices that aren't your own in your head, whispering or saying things to you at different times of day and night. And so those are three things that we don't see in postpartum depression and really are hallmarks of postpartum psychosis.
What does the recovery process look like?
So people can, and I want
to
to be so clear, we can treat this. This is completely treatable. That's the really important thing that I want to say today. Usually you need to be started on an antidepressant and an antipsychotic medication that will reduce the delusional thinking, that will reduce the voices you hear, but you can completely recover from it. It's really treatable. That's like that's really something that I want to make really clear, is that usually hospitalization for some period of time, a week, 2 weeks, depending on the hospital system and on your response to treatment. And then you emerge and you stay on that treatment, but that doesn't mean you're going to be on that treatment forever. We work with your psychiatrist to manage it and make sure that you can be tapered off when the time is right.
And when it comes to talking about, really the more common, the postpartum depression side of things, we know that, demographically, it affects certain groups more than others. Black and Latino women are 40% more likely to suffer from postpartum depression. Rural women are more likely than urban women as well. But we also know this can affect everyone. So how do you even start that conversation?
It's a really great question. So it's important. I always want to make clear to my patients that even if you have risk factors, you're not doomed to this, but I just want you to be aware of it so that you and your partner and your family can just have your eyes open and be monitoring. So things that increase your risk for postpartum depression and anxiety are, this is one of those a previous history of postpartum depression or anxiety. So if you had that with a previous pregnancy, you might have it again. If you previously had depression or anxiety, let's say in adolescence or young adulthood, you have an increased risk. Major events during pregnancy, let's say you lost your job or you lost you and your partner broke up, things like that. Psychosocial factors can also increase your risk. And then obstetrical complications. So if you have a child in the NICU, let's say you've had a complicated or emergent C-section, or you're a premature baby. If you think about the NICU, it's a life and death situation, dark, beeping lights. Like we know that women who have children in the neonatal intensive care unit also have
an intense time.
It's an intense time. So these are all contributing. But again, you're not doomed, and we can prophylax against it, which is something else I want to make sure we say. If I know if a patient has these risk factors, I can start them on an antidepressant at 36 weeks, about a month before they deliver, because they take about 3 to 6 weeks to work. So then at delivery, we go up to a full dose, and then we're able to prophylax against postpartum depression, which is really good for mom and baby.
What medications can't you take when it comes to being pregnant and anxiety medications, or is it really just now I feel like we're getting to now you're a medical student. You're my medical student. These are things I tell the medical students. So there's very few medications that are forbidden. Lithium can cause that wouldn't be a treatment for postpartum depression, can cause some heart defects. Everyone now is a medical student who's listening in. But I think what you're saying goes to the point. You need to keep in touch with your doctor. Keep your medications in line. Some can't mix.
Some can't mix, but that's absolutely a conversation to have with your doctor. And we here in Ohio know that you can be on antidepressants during pregnancy. You should not. If you are stable on your antidepressant, you don't have to stop it before you become pregnant. That's a common thing I see in patients. They'll come to me depressed. They were doing great until someone told them, a grandmother, a friend.
Right.
You can't be on that. And then they stop it and then they get depressed. And then that's not, and again, I don't want anyone to feel doomed or that they're stuck between a rock and a hard place, but it's not like depression is great for you or your baby, right? Like that's going to be associated with other complications. And so, what's good for you is what's good for your baby. You're both on the same team. So if being on an antidepressant is going to help you, there's no evidence that leads to birth defects or anything like that.
And Dr. Gur, what continues to motivate you to do this type of work?
Oh man, my patients, like just knowing that like they can have a better, like it doesn't have to be that bad, and that they can really enjoy their time with their newborns, and that their kids can grow up with a happy and healthy mom. That just like absolutely is so gratifying and so important.
Dr. Tamar Gur, thanks so much for joining us.
Thank you so much for having these important conversations.
Absolutely.